Atrial fibrillation is a heart condition that can change your life in unexpected and unwanted ways. For Dr. Jay Burns, his atrial fibrillation had developed gradually until more serious symptoms suddenly hit him while he was playing golf.
One day I was on the course here right behind me, and I was in this arrhythmia that I'd been in and getting a little more frequent more and more, and it was a hot summer day here in Dallas, and I went down to mark my ball on the green, and I said for the first time, if you stand up now, you're going back down in a hurry. And so I knew something was different, so I sat there on all fours for I guess a minute or so and collected myself, and then knew I wasn't right.
There was a major change in him. When he felt the AFib coming on, he sort of became depressed. He could feel it when he started going into it, and his whole countenance changed. He was a different person. He was just a lump. He didn't have any energy. He didn't feel like doing anything, which is totally opposite of him. And it was sad.
But my life got really bad as far as I was concerned because everything changed. I had to go on medications and the beta blockers that I'd prescribed for so many patients. I had no idea what it did to them in real life. And I went to what I called a really dark place. I lost all motivation. Playing golf just seemed like a burden. Hunting was just too much exercise. I just found myself on the couch all the time, and now I know what people was about depression. It was just, if you've seen the Austin Powers movie, I used to say, I feel like I've lost my mojo.
Dick Phelps had always been a fit and active man who enjoyed tennis and biking. But over time, his energy level decreased, and he often became short of breath.
I started running into periods where I just seemed to be short of breath and unable to be active. Certainly not to play tennis or do anything active. And I didn't really know what was causing that. It wasn't until early 2006 when I had gone into the hospital to do a knee scope that we really found out what the deal was, because the doctor came in and said, we can't do the surgery because you are in atrial fibrillation. And at that point, that was the first time I'd heard that. And then obviously from that, it made sense about what had been going on. And so in some of the more extreme cases, the symptoms would be first almost like a drum roll of the heart. Multiple fast beats of the heart, fibrillation, and then punctuated almost instantly by single pounding heartbeats. If those came along, I knew I had to sit down, stop what I was doing, and just get ready for what was coming on, which was going to be a period of inactivity. It was very debilitating. From the standpoint, this could happen at any time, at any place, and this was on top of the fact I was on medicine to stop the AFib.
The heart's normal rhythm, which we call normal sinus rhythm, is controlled in the right upper chamber called the right atrium. A site called the sinus node fires at a very regular interval, typically about 60 beats per minute at rest, and it can accelerate when patients are exercising. That firing will then activate the upper chambers, the atria, to beat, and then those impulses go down to the lower chamber, the ventricles, to allow those to beat. All of this coordinates the beating of the heart so that it can function very efficiently. In atrial fibrillation, that efficient beating is disrupted. Rather than beating at 60 times a minute, the sinus node is no longer functional, and the atria are beating very rapidly and irregularly, upwards of 350 beats per minute. Those impulses then bombard the lower chambers, which beat very rapidly and irregularly. It's that rapid and irregular beating that causes the symptoms and the problems related to atrial fibrillation.
Well, atrial fibrillation is a technical medical term that refers to a specific type of electrical short circuit that occurs in the top part of the heart. What that means to the patient may be very different depending on the individual. Most commonly, it's the sensation of a rapid palpitating or pounding or skipping, jumping in their chest, a quivering sensation. Because when atrial fibrillation occurs, instead of the heart beating in a nice, smooth, regular manner, it's beating very erratically. It's sort of like crossing the spark plugs on your car and expecting it to run properly. It obviously doesn't. Now, for some patients, they may not feel that. What they may experience is shortness of breath, fatigue, lightheadedness, trouble doing their daily activities because the heart's not pumping effectively and efficiently. Some patients, because the heart's beating very rapidly, can experience discomfort or chest pain associated with it.
There are three main reasons why we worry about atrial fibrillation and why we feel the need to treat it. The first and probably the most important is stroke. Atrial fibrillation is a stroke risk in patients, and their stroke risk is different depending on what other problems they have. So patients who have high blood pressure and diabetes or heart failure are at higher risk than people who have atrial fibrillation and no other medical problems. Fortunately, we have ways to treat that with medicines, and the medicines we choose depend on the level of risk. The second issue with atrial fibrillation is it can cause heart failure. And if people have very rapid and irregular heart rates with atrial fibrillation for extended periods of time, that can weaken the heart muscle. Now, fortunately, that can be reversible, but it's got to be recognized and treated. Lastly, it can cause symptoms. While some patients in atrial fibrillation have very few or no symptoms, many are significantly altered in how they perceive themselves and their lives and how much it impacts on what they do from day to day.
The treatment options for atrial fibrillation are divided into basically two broad categories. We have either medications or we have different ablation strategies, which is a technique by which we can attempt to eliminate the actual cause of atrial fibrillation inside the heart and potentially cure it. Medications suppress the triggering mechanisms for atrial fibrillation and tend to be more of a temporary treatment and don't get at the fundamental underlying problem in the heart that's causing the atrial fibrillation.
There are three classes of drugs that may be prescribed to patients diagnosed with atrial fibrillation. The first is blood thinners. Blood thinners may reduce clotting and the incidence of stroke. When AF escalates, patients may need to take rate control drugs. These drugs attempt to ensure that the ventricles continue to pump blood to the lungs and body, despite the chaotic activity in the atria. Rhythm control drugs attempt to convert patients back to a normal sinus rhythm.
There are a lot of other factors about a particular patient's condition that are important that need to be taken into consideration, such as whether they have high blood pressure, whether they have sleep apnea, whether they have a thyroid condition, a leaky heart valve, whether they've had a heart attack or had prior bypass surgery. All of those are factors that enter into what might be the best approach for a particular individual. We think that a lot of individuals who develop atrial fibrillation do so because of a predisposition that they may be born with. There are a number of other factors that can place individuals at risk, but if we can go inside the heart with a straightforward procedure and get rid of those triggering mechanisms or those clusters of cells that are responsible for causing the atrial fibrillation, that can be a much better long-term strategy.
Catheter ablation is a minimally invasive procedure that can be used when medication fails to control the heart rhythm. The goal of catheter ablation is to prevent unwanted electrical currents from traveling from the pulmonary veins and spreading to the upper chambers of the heart. During the procedure, catheters are used to terminate or ablate these abnormal electrical circuits and stop them from spreading and continuing to cause AF. There are two main techniques used to perform pulmonary vein isolation: radiofrequency RF ablation and cryoablation. One of the main differences between these techniques is the energy source used during the procedure. In RF ablation, heat is applied to the tissue, where in cryoablation, heat is removed from the tissue by introducing cold temperatures. Both types of ablation result in the formation of scar tissue around the pulmonary veins.
I was very excited about a fix rather than a patch because I certainly didn't want to go through the medication the rest of my life, and I knew enough about AFib that even on medication, it only gets worse. and AFib begets AFib begets AFib, and then eventually it's just a lifelong thing that's incurable. So I was very excited about a possible fix. So I began to look at the different options of the fix, and radiofrequency ablation was the best fix at that time, but there was a new cryoablation, and that was a much safer thing to me. I just intuitively made sense. So when I found out that that was a possibility, then I clearly wanted to pursue that.
The ablation procedure is really basically pretty straightforward. A patient comes into the hospital, receives an IV, and then gets a light anesthetic so that they're asleep, basically not aware of what's going on. And then we access the femoral vein in the groin region, much like a conventional heart catheterization procedure. It's a small puncture hole, doesn't involve any stitches. And through that we thread a series of plastic tubes from the groin up into the heart and access the area where most of the atrial fibrillation comes from. And that's the junction where the blood vessels which return blood from the lungs to the heart connect to the heart, something called the pulmonary veins. There are typically 4 of them, and they live on the backside of the left upper part of the heart.
Once we have catheters in the left atrium, we can then measure electrical signals coming from all the pulmonary veins, which are our targets, and then we bring the cryoballoon catheter up into the left atrium in a deflated state. We will then position it near the pulmonary vein we're targeting, and then inflate the balloon and gently apply pressure against the balloon at the opening of the pulmonary vein. This occludes blood flow temporarily and allows us to deliver the cryo energy to create pulmonary vein isolation. After about a 4-minute energy application, the balloon is then deflated and removed away from the pulmonary vein opening, and we can then go back and measure with our electrical catheters whether we've achieved the isolation we want or whether we need to go and do additional energy applications.
The fundamental difference between conventional radiofrequency ablation, which is the technique that we've been doing for essentially the past 10 years for atrial fibrillation, and cryoballoon, is very easy to understand. In the radiofrequency approach, we do a point-by-point ablation. So if the goal is to isolate one of these pulmonary veins, we have to take a catheter and move it, and at each individual dot destroy a particular area of tissue, and do that in a what's called circumferential manner around the mouth of the vein. That requires a greater degree of skill and time and patience in terms of moving the catheter, because remember, the heart's beating and moving the whole time that you're doing that, and you're trying to synchronize the zaps so that you get exactly the right area. The beauty to the balloon is that we're taking it and sealing that whole area, and with one application we're creating a nice circumferential lesion, which is a destruction of tissue by the freezing approach, all the way around where that balloon comes in contact. Not all of the blood vessels are perfectly round, and it does require some unique skill in terms of manipulating and recognizing the way the balloon fits into that location. The risks and complications with this procedure are the same in terms of the types of problems that may occur with any of the other techniques for ablation that we've been doing over the past couple of decades. Anytime you access a blood vessel, there's always the risks of puncturing, bleeding, blood clots. We're using anesthesia, so you could have some sort of a drug reaction. Inside the heart, when you're working, there's a risk of a blood clot that could cause a heart attack or a stroke. There's the chance of puncturing a hole in the heart, which could cause bleeding that might require surgery to repair that. Fortunately, these are very rare occurrences.
The other potential risk with a cryoballoon ablation is damage to the phrenic nerve. This is the nerve which comes from the brain down to the diaphragm and helps control breathing. This can be damaged with a cryoballoon energy delivery, and currently during the procedures we test this nerve during the energy delivery so that we can stop it at the first sign that there's any injury. Following the procedure, most patients will spend the night in the hospital. Typically, they'll be discharged the next day. There are very few side effects related to the procedure. The most common area of discomfort would be some mild discomfort at the site where we get access with our catheters in the groin area. Few patients may have a little bit of chest discomfort, but other than that, most are fairly symptom-free.
They lifted the anesthesia and I came out of it. And my initial reaction was, wow, this is just as smooth as it can be. And it was that way from then on.
Some patients may still experience several episodes of atrial fibrillation as the ablation sites are healing, but these should go away within a month or so after the procedure.
We had an expectation given to me by the doctors that said that the heart is trained to AFib and that it is not unusual and is even expected for it to happen perhaps one or more times after the surgery. In my case, I had one episode that lasted about 3 or 4 hours. And after that, there was no more AFib.
For the next week or so, we want them to try to avoid excessive physical activity to allow the sites where we've gained access in the leg to heal up properly. Most will also be on blood thinners for at least a month or so after the procedure.
Right after the surgery, there was a need to go on Coumadin, and that was both a precaution from the surgery itself, as well as just any AFib that might occur, keep the blood thin and prevent the clots and so forth, the complications that go with that. So that was continued for several months after the surgery, but I did not have to take any AFib medicine at all. After a period of time, stopped the Coumadin, and I've not had to take anything since then. As far as coming out of the surgery and finding this smoothly beating heart, I like to liken it to an old Chevy 350cc V8. This heart had been given a new distributor cap, new points, new cables, and new spark plugs with platinum tips. This thing hummed. It just did super. It just ran beautifully.
I honestly can tell you I feel better than I've ever felt in my life. And I'll tell you a thing that I didn't really appreciate is that I thought I was better at a month and 2 months after the procedure. But when I got off my medications and there was something about getting off my medications that made it better. But there was something else about, I think that when you're in and out of AFib, I'm firmly convinced that it's a more metabolic demand. Your heart's not functioning efficiently, so you're more tired than you really think you are. I thought I was back to normal at a certain point, but once I got off all the medications and I was out of my AFib for a month or two, all of a sudden I went, oh yeah, this is how I used to feel. And I'd lost that.
Well, I was thrilled when I realized that the problem would be solved, that it was successful.
Yeah, I can tell you right now I'm in better shape than I've ever been in my life.
I was so happy for him because I think he was, we so look forward to the years ahead, especially since we're empty nesters and, all these things we're going to do. And I think before the procedure, he thought, was wondering if he was going to be able to do the things he wanted to do. Can I play golf? Can I still go hunting? And can we travel? And so it was like a whole new lease on life. Like, I've got my life back and I can do those things now. So it was very emotional, we were very happy.
And there's a lot of people, they think it's an old person's disease, and at 55, I don't think I'm that old, and I'm still doing a lot of stuff. And I want to tell people, make sure, you can be scared, but make sure you're scared for the right reasons. You got to realize that AFib is something that's going to continue and get worse. There is a way to treat it. Not everybody gets a great result like me, but most people get a really good result. and if you don't do anything, it's only going to get worse. And I think there's a very safe way to do it now, and you ought to at least look into it rather than just sit back and accept your fate. I'm so glad I didn't.